Hello, Trav and Julie Chase. This is Out About Nashville. We are continuing our coverage of the first annual Southern LGBTQ Health Symposium at Vanderbilt University. Dr. Adam Huggins will be chatting about gender affirming surgery in just a few minutes. We will also be broadcasting another presentation next door about community relationships if you wish to tune into that. This is Out About Nashville.
So if we give us some paycheck, here's a solid. We'll share some paycheck. Yeah, very close with this. What you guys want? I got this time today. I got things done. Yeah. So, what's your work? It's a collaboration with the university. We're gonna set like simple nights down. We're gonna have like a yearly conference. We'll figure it out. It's like my friend and I just get text messages, but like we get this like these PowerPoints that are really like ridiculous, like absurd type meme things, and we created these like flyers that's like grad student existentialist children's literature project, and we're going to set up like rooms at Michigan and wow, get this. I'm gonna go together. Yo, hang out. Grab it.
Hi.
Hey.
By the way.
How rude. Yeah. How you are? Are you a medical student at Vanderbilt? Oh, that's awesome. No, I go to the University of Cincinnati. Oh, where? Oh. So how'd you why'd you do Vanderbilt? Do you know, I mean, how deep into your studies are you?
Sorry.
How deep into your studies are you?
I'm just studying 7 months.
Oh, okay. So you don't know like what you want to do for residency or anything yet? Okay.
What do you study?
I study neuroscience.
Oh, cool.
Yeah,
So
but
undergrad?
yeah, but I don't want to do that. I don't want to be a doctor. I mean, I do want to be a doctor. I don't want to be a MD.
Gotcha.
Yeah, cool. But
So interested in like PhD? Or...
yeah. Oh, yeah, yeah. Like in biostat or like clinical neuropsych. I'm not sure.
One seat there, maybe. Right, is that your chair? So there's one seat there if anybody needs a seat. This looks like about everybody, so I'm going to go ahead and get started in the interest of everybody's time. My name is Adam Huggins. I am one of the assistant professors in the Department of Obstetrics and Gynecology here at Vanderbilt University Medical Centre, and also the assistant medical director for the gender clinic here at Vanderbilt. I have no disclosures and no conflicts of interest, other than the fact I don't like standing behind the podium, but I don't have a way to flip the slides, so I'm going to be sort of stuck here. But if you have any questions, please feel free to raise your hand at any point during the presentation. I'll be happy to answer them. So our goals and objectives today, first we're going to start off by talking about some of the background statistics that help describe the transgender population, both in the United States and here locally in Tennessee, to help us understand more about this population, who they are, and some of the obstacles they face both in society and when accessing healthcare. We're going to explore a little bit more about why these patients, some of them elect to have surgery and what their goals are. Review some of both the clinical and insurance guidelines for care and what their requirements might be before they can receive surgical care. We'll discuss specific considerations for both male to female surgery and female to male surgery and in relation to their hormone therapy and their fertility options and other surgical procedures they may want. We'll look at some of the long-term follow-up, similar to what Dr. Bullock talked to, some of the long-term follow-up and health maintenance items that they may need to pay attention to depending on what surgical services they have. And then lastly, we'll talk a little bit about some of the institutional policies and items that we've implemented here at Vanderbilt that may be of use at facilities where you guys work and train. So just a little bit more about myself. I'm a board-certified OBGYN. I moved to Nashville in 2009 and was in private practice for about 4 years in Nashville before I joined Vanderbilt about 5 years ago. My first ever experience with a transgender patient was actually in medical school in 2005 when I was studying in Switzerland for a month. and we did a hysterectomy on a transgender male patient. That was the first time I ever remember coming across or taking care of a transgender patient, although in reality I'd probably cared for or come across transgender patients before and probably was just not aware of it. Here at Vanderbilt, my first experience was when I had a partner who was not comfortable taking care of a transgender patient and referred that patient to me for surgery. We ultimately did that surgery for that patient. He did very well, and that led to other referrals. Ultimately led me to get involved with the gender committee here at Vanderbilt about 2.5 years ago, and now I'll be the assistant director for the clinic, which should open later this fall. Just of note, this will be one of the only clinics in the country that offers comprehensive care at a single setting for transgender patients. That includes endocrine, mental health, social work, gynecology, med peds, and surgical services all in one clinic. There are a lot of other comprehensive care centers in the country, but not all of them offer the full range of services. So we're very excited to have that clinic. We think it'll be a huge asset for our patients in the Southeast and even in the country. So let's start talking a little bit about who the transgender population is in the United States and how many transgender people we think are in the United States and where they live, et cetera, so on. So as you can see from this map, they live all over the entire country. The average is about 0.6% of the entire population. That's about 1.4 million people. This is based on one of the largest surveys that was done back in 2015. That ranges from about 0.3% in North Dakota all the way up to 0.8% in Hawaii. This is double previous estimates. So previously we thought it was much, much less, and as more and more people are becoming comfortable identifying as transgender, we're seeing the overall population size grow. The millennial demographic of 18 to 24 is the demographic most likely to identify as transgender. And just to put the 1.4 million people in scale or in context, if you look at the sort of sickle cell anemia patient population or the cystic fibrosis patient population, that's smaller than 1.4 million people that identify as transgender. And you hear a lot about sickle cell anemia or cystic fibrosis. It's about the same number of people that have Asperger's syndrome as population size as the transgender population. So it's a very significant patient population. Here in Tennessee, we actually rank 10th nationally, which surprised me a little bit when I first saw that, but for overall number of transgender patients, we have approximately 31,000 people in Tennessee that identify as transgender, 0.63% of our population. So I'm going to take the next several minutes and talk a little bit about some of the background statistics that, like I said, help sort of describe more fully the transgender population, both nationally and locally. These are statistics that were very eye-opening to me in many ways, and I think will be eye-opening to you for those of you that may not be as familiar with all the statistics. This is all based on a 2015 transgender survey, U.S. transgender survey, that surveyed about 27,000 people, transgender people, and recorded all their information for experiences they had had both socioeconomically and in relation to healthcare. These are just some of the highlights looking at some of the socioeconomic status. So as you can see, up to about a third of transgender patients live below the poverty line in the United States. That's about 3 times the national average. Unemployment is anywhere from 3 to 5 times the national average in the transgender population. When it comes to transgender transgender people or population in school, approximately half of them are verbally abused, and up to a quarter of them are physically abused in schools, the K through 12. When we look at the workplace, about a third of them report either having been fired or not promoted or discriminated in some way for being transgender in the workplace. Here in Tennessee, you see about a third of them have been verbally harassed for being transgender. And of course, the statistic that's certainly gotten the most news coverage in the last couple of years, access to bathrooms with the various state legislation passing laws discriminating in bathrooms. You see about 1 in 10 or so are denied access to bathrooms, and about the same number are harassed when trying to access a bathroom that they are gender congruent. Looking a little bit closer into healthcare disparities, about 1 in 10 transgender people are discriminated or abused in their own household when they identify as transgender. So that can be verbal or physical abuse in their own household. About 40% or so report serious psychological distress. That could be major depression, that could be anxiety or other psychological diagnoses. That's about 8 times the cisgender population average. Attempted suicide, Dr. Bullock hit on this a little bit earlier, 40%. That's an astronomically high number. That's 10% the 10 times the national average. That's a crisis in and of itself. HIV rates in the transgender population are 5 times higher than they are in the cisgender population in the United States. And then about 20% or so work in the underground economy here in Tennessee, again, based on several of the other socioeconomic factors that are involved. When we talk about healthcare disparities or healthcare access disparities, this really hit home to me a lot too because I am in healthcare, obviously. It really helped me understand just how important it is to have identifying documents that are congruent with your gender identity. So only about 10% of patients in the transgender population report that all of their identifying documents, their driver's license, birth certificate, etc., so on, match their gender identity. 80% report that none of their documents match their gender identity, and that a third of them are harassed when they present an identifying document that does not match their gender presentation. And that can certainly lead to difficulties with insurance coverage. As you see, only about 20 to 25% report instances of insurance denying care. And that could be something as simple as if they are trans male but then get pregnant. Insurance doesn't cover pregnancy in men. Insurance doesn't necessarily cover pap smears in men. But these patients certainly need this care and deserve this care. And if they don't have their identifying documents, or in some cases they get their identifying documents to match their gender identity, they may still yet be discriminated against by the system. This one really struck home to me, which is why I've got it highlighted. About a third of transgender patients report a negative experience when accessing healthcare. That could be anything from as simple as not using the gender pronoun that they prefer to actually being harassed or abused in the healthcare setting. That to me is fairly appalling. 14% in Tennessee report that a mental health professional in the last year tried to stop them from being transgender. That is also fairly appalling. And that really leads to the last statistics where we see 1 in 4 transgender patients avoid seeking healthcare because they're concerned about the negative experience they may have or the difficulty they may have in accessing healthcare. And this could be, the serious mental health conditions that they may have, or HIV, et cetera, so on. This could be something as simple as a routine annual exam, or if they have a small acute illness. So again, as those of you who are in medical education, or those of us that are in medical professionals, this is absolutely key for us to try and overcome this and make our institutions more accessible, more friendly, and more comfortable for the transgender population. So moving on to gender affirming surgery, we really break this down into 2 basic categories: surgery that affects fertility, and surgery that doesn't affect fertility. For our trans male population, that certainly includes things like a hysterectomy or removal of the ovaries. For the trans female patients, penectomy or orchiectomy, removal of the testicles. There are still a variety of other surgeries out there that patients may get that do not affect fertility, and that ranges from major surgeries such as genital reconstruction, breast augmentation or mastectomy, to more quote-unquote kind of minor procedures like blepharoplasty, chondroplasty, hair removal, liposuction, etc. When we think about how many patients that are transgender actually have surgery, it's actually a minority. There's a good study from Fenway Health in Boston that showed that only about 35% of transgender patients ever get any kind of surgery at all. So the majority of transgender patients are very happy with either hormone therapy alone or just whatever other measures they have taken in their transition or may not be ready for surgery. Of those who access surgery, it's more commonly male to female transition. And of those who access surgery, it's more commonly surgery that does not affect fertility. So some of the other kind of quote-unquote more minor surgeries that I was discussing earlier. However, the American Society of Plastic Surgeons last year, or 2 years ago, released a press statement that they had seen a 20% increase from 2015 to 2016 in the amount of gender-affirming surgeries that they are performing. And I think that's really a result of,
insurance.
Taking the words out of my
Recently, there's no insurance coverage. That's
spoiler alert.
such
Exactly.
a small number of people want surgery.
So
It's like $30,000-$40,000. You got that sitting in your bank account.
So that is exactly what I was about to say. I think as more and more patients are comfortable identifying as transgender, they are seeking care. And certainly as the insurance guidelines, which we'll speak about in a few minutes, are kind of catching up to the patient population, we're seeing more and more surgeries being covered. So I think it's reasonable to expect that the number of patients that are getting surgery will certainly continue to increase over time. When we think about why do transgender patients seek surgery or why do they not seek surgery, again, to echo what Dr. Bullock was saying, I think the most important thing is for us to have a really detailed, comprehensive conversation with our patients. And this may take 2 or 3 visits to do, but you need to really understand what your patient's goals are in their transition and how surgery either does or does not play a role in their goals. Every patient's a little bit different, and some of them have different desires for different surgeries for different reasons, and you need to be able to understand what they are looking for and how you may or may not be able to help them with the services that you provide. Certainly, the effect that it has on psychiatric distress and anxiety is a big reason why many patients seek to have surgery. There's a great study, again, from that large survey that showed a 15% or so reduction over 10 years in serious psychological stress once they've had gender affirming surgery. Excuse me. In addition to that, we also look at things like what are the incidents of regret, and Dr. Bullock hit on this a little bit earlier. There's actually another study from the Netherlands that looked at 6,000 patients from 1972 to 2015, probably the largest study that's out there, looking at surgical regret. And for patients that had gonadectomy or otherwise irreversible fertility affecting surgery, the incidence of regret over time was 0.6% in that study for 6,000 patients. So it's less than 1%, and it held steady over time, even for the older cohort of patients and the younger cohort of patients. So, although it's important to discuss with patients, and we'll talk about this a little bit later, how surgery may or may not affect their fertility, I certainly wouldn't use potential regret as a reason to withhold or counsel somebody against having surgery, because the data just doesn't support that. And last but not least, again, to refer back to statistics, the reason I think this is really important, and the reason I wanted to bring up the context of cystic fibrosis patients or sickle cell anemia patients or even Asperger's, is that if we said that 1 in 10 Asperger's patients are abused in their home, or 40% of cystic fibrosis patients were trying to commit suicide, I really think there'd be a national outcry about that. And I think because as a country we're not comfortable talking about gender, sexuality, this sort of gets brushed to the side. And I think, again, as part of my role is educating future healthcare providers. I think it's important that we address that and we be more comfortable talking about it, because this is definitely a huge population that has very significant healthcare needs that we have really kind of overlooked in many ways, and it's really critical that we pay more attention to that. So some of the clinical guidelines that we use for gender affirming surgery, a lot of it is based off of WPATH, which is the World Professional Association for Transgender Health. This is the largest international group that issues guidelines and reports a lot of data on the transgender population globally. And so most institutions in the United States tailor their guidelines, and certainly we here at Vanderbilt in our gender clinic have tailored our guidelines essentially in lockstep with WPATH. And just to run a few of the details, certainly we want to have a patient that has a well-documented persistent gender dysphoria diagnosis. As we talked about a little bit earlier with Dr. Bullock, that it's somewhat controversial about whether or not they need a letter from a mental health provider before starting hormone therapy. But certainly when you start to talk about things like surgery, all the guidelines really do recommend a letter from a mental health provider to rule out other psychiatric diagnoses that may be going on that may present with some sort of gender discongruity. The ability to make informed consent obviously is key for surgery. They need to be of the age of majority. That's for WPATH and certainly for Vanderbilt here. As with any other type of surgery, any significant mental health or other physical medical diagnosis would need to be well controlled prior to surgery. And again, that would be true for any kind of surgery. Going back to the letters for what's considered either upper body or quote-unquote top surgery, the recommendations are to have at least one letter from a mental health provider documenting gender dysphoria and ruling out other diagnoses. For quote-unquote bottom or fertility-affecting surgery, they need to have 2 letters from 2 separate providers, again, documenting gender dysphoria and ruling out other diagnoses. And for patients that are going to have fertility-affecting surgery, we recommend that they be on hormone therapy for at least 1 year and have been living congruently as the gender they identify with for at least 1 year. And the reason for that is that many of these surgeries obviously are not reversible, and we want them to have experienced a full year of birthdays, holidays, anniversaries, work events as the gender they identify with, to make sure they are really fully comfortable in the gender they identify with and wouldn't have any concern about having a surgery that would otherwise be irreversible. As far as insurance coverage goes, these are the largest insurers here in Tennessee, and fortunately they are evolving to follow most of the WPATH and subsequently Vanderbilt guidelines as far as what they will or will not approve. Typically, top surgery such as mastectomy is approved essentially across the board. If you have any concerns about what policies they have, you can certainly go on their websites. I found it fairly easy to go and look up their transgender care policies and see what was or was not covered. Breast augmentation, unfortunately, is variably covered because it can be considered a cosmetic surgery, whereas opposed to mastectomy often is covered straight away. Most of the sort of fertility-affecting or quote-unquote bottom surgeries are covered essentially straight away, assuming they meet the criteria. Their criteria, again, are very similar to WPATH, so 1 to 2 letters depending on whether or not they're having top or bottom surgery, that they've been living for 1 full year or longer as the gender they identify with, and they've been on hormone therapy for 1 full year or longer. Unfortunately, the cosmetic surgeries, and I put cosmetic in quotes because depending on what your gender identity is and what your goals are in your transition, this may not be considered cosmetic to you, but what the insurance companies consider to be more cosmetic type surgeries often are not covered and can be very expensive. And there's some examples listed here. Medicaid in Tennessee is as can be per usual, lags behind a little bit, but is coming around a little bit as far as what they will or will not cover. And for providers in the room that are looking for easier ways to get their patients covered using the ICD-10 code, F64 for gender identity disorder is often an easier way to get your plans or your care covered. So here I want to mention one notable exception to gender affirming surgery to the WPATH and Vanderbilt guidelines, and that's with UCSF. UCSF is one of the largest transgender care centers in the country. They have a much more nuanced approach for transgender minors, so patients under the age of 18. And in many cases, they actually advocate for surgery in those patients. They cite the significant psychosocial distress of going through puberty as a transgender youth and the effects that can have. They also cite specifically the physical problems that can arise from inappropriate chest binding, the physical or psychological distress of developing male genitalia as a trans female patient, particularly with intimate encounters during their pubertal years. That can even result in abuse from partners. And so for those reasons, they recommend that providers discuss and offer surgery to patients under the age of 18. And if the insurance company denies it, they go as far as recommending that the providers work as an advocate on the patient's behalf to petition the insurance company to help get approval. Again, that's not something that WPATH expresses, and certainly not within the policies here at Vanderbilt, but I think over time those are policies that are worth having a discussion about, and certainly on a case-by-case basis may be necessary. So I'm going to talk a little bit more now in depth. We're going to start with sort of female to male transition surgery, and then we'll move from male to female. But when we're talking about female to male transition surgery, gender affirming surgery, it's critical to, again, and you'll hear me say this over and over again, really discuss with your patient what his or later her goals are in surgery, what their goals are in their transition, and how surgery may or may not help. So for trans male patients, we want to talk to them about, does a hysterectomy make sense for their transition? Does removal of the ovaries make sense for his transition? How does that affect future fertility? How does that affect future hormone requirements? And do they have desire for genital reconstruction? What are their goals for genital reconstruction? Because all of these things come together to make a comprehensive surgical plan for how you might do surgery, what surgery may do, and what that may mean for their long-term health. So when it comes to hysterectomy, which is one of the most common fertility-affecting surgeries for trans male patients, you want to have a discussion with the patient about why do they desire a hysterectomy? Is it for simply gender affirmation, or perhaps that trans male patient has heavy painful periods that they want to get rid of, or perhaps they have fibroids or pelvic pressure or other diagnoses that hysterectomy may help with. And so that is helpful in understanding, so you can plan the approach to the hysterectomy. From the OBGYN literature and from our guidelines, we know that vaginal hysterectomy is the least morbid, least complicated, and least invasive approach for hysterectomy. And so you want to discuss with the patient the modes in which you may do a hysterectomy, because there's several different ways to do a hysterectomy. However, in a trans male population, vaginal hysterectomy may be difficult. These patients often have never had children vaginally, and may or may not have had any kind of regular or even penetration at all vaginally. So technically, a vaginal approach may be very difficult. You might require a referral to a specialist. Otherwise, you may choose an approach like a laparoscopic hysterectomy rather than doing an abdominal hysterectomy. As far as removal of the ovaries or gonadectomy in the trans male patients, again, we recommend waiting until 18 years old so they have completed puberty. But you need to discuss with them again, what are their goals with surgery? What are their desires for future fertility, or to be able to have a child that is genetically theirs, and how that affects obviously their future hormone requirements. With regards to future fertility, both the ASR and the SART, which are two big reproductive societies, have stated in their 2013 guidelines that cryopreservation of eggs or freezing your eggs is a very reasonable option for preserving fertility for the future. In fact, they've done studies that show that using either fresh eggs versus frozen eggs for IVF is equally efficacious. So whereas that used to not be a technology that was available maybe 10 or 15 years ago, it's now a technology that is readily available and reliable. Unfortunately, as you can see, it is very expensive. It can cost $5,000 to $10,000 to do, depending on the institution that you use. And that does not include the hormone therapy they would need to be on to ovulate and to retrieve the eggs. So it can be an expensive process to undergo, but it's important to have that conversation with your patients before you consider removing their ovaries. With regard to their future hormone requirements as to whether or not you remove their ovaries, it's important for the patient to understand that if you leave their ovaries behind at the time of hysterectomy, they may ultimately require a higher dose of their testosterone therapy to achieve the physiologic results that they are looking for just from the native effects of the estrogen. If you take out their ovaries, you have to understand, the patient has to understand what the detrimental health effects may be. We know from the OBGYN literature, there was a great study that came out in, I think, 2009, looking at about 27,000 patients that had premature surgical menopause, and we know that it has negative effects on genetic females as far as health disease, such as cardiovascular disease, bone disease, and dementia, as well as mortality from all causes, even things like lung cancer. So for your transgender male patients, you need to counsel them that if they have their ovaries taken out, they have to stay on physiologic doses of testosterone at least through the age of average menopause, so 50 to 51 years old, so they get some indirect estrogen to help protect their heart, help protect their bones, help protect against dementia and other. And should for some reason they decide in the future that they want to come off their testosterone or need to come off their testosterone, you have to be able to have the discussion with them that they should probably have some type of estrogen replacement, which obviously may counteract some of the effects that they've been looking for as transition to men. So again, it's important to have these complex discussions and make sure the patient really understands and has an informed consent for what it means to take out the ovaries or not. When we look at genital reconstruction, again, it's important to understand what the patient's goals are. A lot of patients don't actually get genital reconstruction, but for those that do, you certainly want to understand what their goals are behind that. Is it important to be able to stand when they urinate, so that when they are in the male bathroom, they don't always have to go to a stall to urinate. They can stand to urinate. Is it important for them to be able to have penetration when having sexual intercourse? Because that can mean very different things for the type of procedures that you get. There are several different options for procedures that you can have, from metoidioplasty to phalloplasty and scrotoplasty. Metoidioplasty is using the hypertrophied clitoris that's been exposed to testosterone to create a neophallus. That usually results in a shorter neophallus than phalloplasty does, but does have a more appealing cosmetic appearance, closer to a traditional male penis, and does preserve a lot of the quote-unquote like sensations, so that patients have the ability to orgasm more readily than the traditional phalloplasty. Phalloplasty results in a longer neophallus, so penetration is often a little bit easier with phalloplasty. Standing urination is often a little bit easier with phalloplasty. The biggest thing to counsel these patients about when it comes to genital reconstruction is often the difficulties are encountered with what's called urethroplasty. So for the non-clinicians in the room, that's certainly connecting the ability to be able to stand and urinate, extending the urethra so that they can stand and urinate. The complications from that procedure are anywhere from 30 to 40%. That's incredibly high for all those surgeries that we perform typically. And those complications can range from urethral stricture to fistula formation to something as simple as dribbling after urination. So again, these patients really need to understand what they're getting into and what it may mean to have these surgeries. Unfortunately, there is not a reliable database that's readily accessible looking at surgeons across the United States, what their outcomes are, what their complications rates are, and what their success rates are. And so patients really have to do their own individual homework to try and research their surgeon, the facility their surgeon operates at, and what their outcomes are, and should really ask a lot of questions about what are your complication rates, what are your success rates, what do your patients say, can I talk to some of your previous patients, et cetera, so they can get a better sense of what kind of surgery they may be undertaking and who their surgeon really is. And unfortunately, patients, even they're getting, quote-unquote GYN surgery from me, almost never ask those kind of questions, and really all patients that get any kind of surgery of any kind should always ask those questions, whether it's something as simple as a gallbladder coming out or something as complex as genital reconstruction. When we talk about male to female transition surgery, again, we want to talk about what the goals are with the patient and what kind of surgery she may want. It's important that trans female patients be on hormone therapy for 1 year, particularly if they're considering top surgery. So after 1 year of hormone therapy, they will have the maximum effect that the estrogen will give them as far as their own breast development. So before they make a decision about whether or not they want any additional breast surgery, they should be exposed to that estrogen for 1 year, so they know what kind of breast development they'll get from their hormone therapy alone. And then they can decide whether or not they want to do any additional procedures for their upper body. With regards to lower body, again, you want to know what their goals are. Do they want a neovagina created? Do they want labiaplasty or not? Because then you can decide what type of procedure you may use. There are versions of penectomy that involve penile inversion to create a neovagina. If that's not an option, then you can use portions of the colon to create a neovagina. There are a variety of other things out there. You can use portions of the scrotum to create neolabia. So again, having that discussion with the patient to understand what her long-term goals are down the road for genital reconstruction is important. There's great data to show that in many cases with neovagina creation, that patients have both great cosmetic results and functional results, and often maintain the ability to have orgasms. So these surgeries seem to be largely more successful than trans male genital reconstruction.
I hate to interrupt again, but the real life experience of 12 months, one of the most important things is if you're a trans woman, you have to find out what it's like to live as a woman in the United States. If you spent your life as a male, it is a
Sure.
different universe. And it actually goes that way to a certain extent. I have trans male friends who are kind of shocked at the things that males actually do. And there is a real social adjustment and cultural adjustment in terms of how the two different genders are allowed to behave, how they're treated, who ignores you, who pays attention to you.
Yeah, no, those points are all very well taken. I couldn't agree more. Further considerations for male to female transition surgery. Again, the statistics show that it's a minority of these patients that ever undergo surgery in the first place. But you want to talk to them a little bit about their hormonal considerations and their future fertility as well. Testosterone, unlike estrogen, doesn't provide all the same physiologic effects or benefits to the body that estrogen does. Primarily for men, it provides bone health and metabolism, as well as libido. But a lot of it is secondary sex characteristics, such as voice deepening, hair pattern development, etc., muscle mass. And so for patients that are trans female, they're often already on estrogen anyway, so they're getting bone protection in many ways anyway. So losing the testosterone is often not quite as critical as losing the estrogen for the trans male patients. For fertility preservation, of course, I think most people are familiar with freezing the sperm. That technology has been around for a very long time and is very, very successful and is often much more affordable than freezing of eggs, often only a few $100s. Although, as Dr. Bullock pointed out, certainly if patients have been on estrogen for a long time, the ability to retrieve sperm in a sample may be much more difficult. So some other perioperative considerations just in general, no matter which way you're transitioning. The biggest one is really what to do with these patients' hormones as they're coming up towards their surgery. All of these hormones, as Dr. Bullock pointed out, are thrombogenic, in other words, they increase your risk for blood clots. And so we recommend stopping the hormone therapy 4 to 6 weeks prior to surgery and then delaying the restart until 4 to 6 weeks after surgery just to minimize that perioperative blood clot risk. From an institutional level, there are several things that I think we need to do a better job of, and some institutions need to do a job, just period, to make your center more comfortable and inclusive for the transgender population. And this can be everything from, of course, staff education in the clinic and in the hospital about gender pronoun use and about what it means to be transgender and what these patients may or may not be going through and what their particular health risks may or may not be. You want to look at your EMR. So here at Epic, for those of you that are here, this is your horror shot of Epic. We have very good SOGI data in Epic, and so we're able to capture sexual orientation and gender identity. It's important to include the, doesn't want to answer as an answer. So many transgender patients may be uncomfortable answering some of these questions or may not know the answer to some of these questions depending on where they are in their transition. So it's important to have that as an option so that we're not trying to pencil everybody into a little box to make them fit our forms. You want to take into consideration what your letterhead looks like. So if I operate on a trans male patient and write for him to be out of work and I send a letter to his HR office that says Center for Women's Health at the top, I've sort of inadvertently just outed this patient. So we have to really think about even little things like our letterhead to make sure that we're not providing information about a patient that patient may not have provided to his or her workplace or to his or her peers. And then, of course, surgical coordination. A lot of these patients may be undergoing multiple surgeries at the same time. And so in many cases, we've done hysterectomies and then done mastectomies at the same time. And it just saves the patient from having to have multiple surgeries over multiple times where they can just be put to sleep once and have one longer surgery. So if the patient in your discussions wants to have multiple surgeries, it may be worth sending them for referrals with other surgeons to try and coordinate your surgeries to be able to provide the patient one surgery that's more comprehensive if feasible. So lastly, we'll talk a little bit about some of the long-term care and long-term considerations for patients that have undergone gender affirming surgery. So for our trans male population, cervical cancer and breast cancer screening, and then we'll talk a little bit about endometrial cancer and ovarian cancer. For transgender men, they are less likely to be up to date on their cervical cancer screening for many of the reasons we talked about with access to healthcare and their ability to access healthcare. But as long as they still have a cervix, they follow the same guidelines that cisgender women follow. And that's based largely on what their pap smear history is. I won't get into all the details there, but for transgender men that still have the cervix, they do still need to be screened at the same intervals that a cisgender woman would be. If they've had their cervix removed, it will depend on whether or not they've had moderate to severe dysplasia in the past as to whether or not they ever need another pap smear again. So if you are a healthcare provider and are not sure about the updated pap smear guidelines, please contact an OBGYN in your community that can help guide you through that for that patient, so that patient's not getting unnecessary exams or unnecessary tests when they don't need it. Of note for trans men, because they are often on testosterone therapy, that can lead to even 10% of pap smears being unsatisfactory. So it's important to get a very good swab and certainly mark the pathology form that the patient's on testosterone, so the pathologist reading this pap smear specimen will know that that patient's on testosterone and look close at the specimen. With regards to breast care for trans men that have not had their breast tissue removed, they follow the same screening guidelines as Dr. Bullock mentioned, depending on which college you look at, ACOG versus American College of Radiologists, etc. Those guidelines vary a lot, which makes it hard to make uniform guidelines for these patients. But for our recommendations as OBGYN would be to start breast cancer screening at 40 and then surveillance thereafter. If they have had their breast tissue removed through a mastectomy, screening guidelines are even less clear if they have no breast tissue or minimal breast tissue remaining. But certainly if the patient ever develops a lump or a mass or has any kind of complaint, it's worth being evaluated, and the modality we would recommend would certainly be either ultrasound or MRI at that point. For uterine and ovarian cancer screening, this is an important point. Testosterone therapy, testosterone will be aromatized somewhat to estrogen in the peripheral tissues for trans male patients. And if they still have their ovaries in place, although many of them will have inactive endometriums and won't have periods at all, if you have a trans male patient who's on testosterone and still has his ovaries and has any bleeding at all, they have to be worked up for endometrial cancer or endometrial hyperplasia. As unopposed estrogen certainly is a risk factor for that, and so that includes either an endometrial biopsy or some sort of tissue sampling surgically to rule out any kind of endometrial cancer. If they have had their uterus removed, obviously that is a moot point. Testosterone therapy has not been known to increase the risk for ovarian cancer, and importantly, there is no reliable screening test for ovarian cancer to begin with, so these patients certainly, if they keep their ovaries after any kind of surgery, don't need any type of routine screening for ovarian cancer, but certainly if they develop any sort of symptoms, whether it be pain or fullness or other sort of symptoms, they would need to be worked up appropriately. As far as vaginal health goes, for patients that are on testosterone therapy that do not have a vaginectomy, it's important to counsel them. They are going to likely have an atrophic vagina, and atrophic vagina is certainly associated sometimes with discharge or dryness or itching, and so that can be treated and evaluated symptomatically as needed. For trans women surgery, or trans women patients, in the surgical transition, vaginal maintenance is an important thing. If they've had a new vagina created, they need to be educated on what it means for them physiologically. Counsel about hygiene and certainly STI prevention. UTIs are more common in women than they are in men, so for trans women that have had genital reconstruction, they now have a shorter urethra than what they had before, so UTIs are more common. So again, hygiene is more important for these patients. Neovagina, depending on the source of the tissue, may have more discharge than normal, and that can certainly be evaluated symptomatically. And of course, neovaginas have to be maintained both for caliber and length, so that can be done either through regular penetration through intimacy or done with medical dilators through regular use of medical dilators. Prostate removal of testes and estrogen therapy certainly reduces your risk for prostate cancer. As Dr. Bullock highlighted, the screening for prostate cancer, even in cisgender men, is becoming more and more cloudy than it used to be, where we used to do PSAs for everybody and the prostate exams. That is certainly changing. But should the patient need an evaluation for prostate, that can be done either transvaginally if they have a new vagina, or certainly with the vitreorectal exam, either way. Breast health for trans women is a little bit more murky. We know these women have a lower lifetime risk for breast cancer because they are exposed to estrogen and progesterone for less amount of time than a cisgender woman. However, they tend to have more dense breasts than cisgender women, so evaluation with traditional mammography can be more difficult because of breast density. The data is limited on the best way to screen these patients, again, mainly because the screening guidelines for cisgender women is also not completely aligned. But most groups agree that screening should start at approximately age 50, and certainly after 5 years of exposure to estrogen, and then just screen about every 2 years thereafter. And this is a picture of sort of the final frontier to say, we really are on the edge of the frontier for care for these patients, and particularly surgically. And so I think this is an opportunity for those of you that are in medical education to take this as a calling, for those of us that are providers to take it as a calling, to say, what can we do to really improve the care for transgender patients? What can we do to coordinate care for transgender patients, whether that's in our own institution, in our own community, or between institutions nationally or globally? There's a ripe opportunity for research. There's a ripe opportunity for development of protocols and refinement of protocols. And so for those of you that have the time and the interest, I would recommend that you get in touch with those of us that are in the gender clinic, with those of us that are community involved, and try and see what you can do to help, because there really are a lot of opportunities to care for this patient population. I would be remiss if I didn't thank certainly Jesse Ehrenfeld and Ted Anderson who helped me kind of put all this all together. With that, I'll take any questions.
Percentage that you said in surgery. So in the military, we had a dilemma because the RAND study that came out said, 12%, 20%, nobody wants surgery, everybody's happy. In our system, surgery can be free. Everybody wants something. Now, that's not to say that they want the whole deal, but we have facial feminization surgery, tracheal shave surgery, top surgery, bottom surgery. And the whole problem with the military is it's about a 3-year total time span. And the money, they say it's a drop in the hat. When you start adding it up, it's not. And, General Mattis just said, you can't deploy in 12 months, you're out. So we have a dilemma. But my point is that the RAND, I think you brought it up. The reason nobody wants surgery is nobody can afford surgery. Right. So when surgery is there,
sure,
it's 100% will want something.
Yeah, and then the study I quoted from Family Health was percentage of patients that get surgery, not necessarily patients that want surgery. Right. And so I think you're right. I think there's probably a much larger, probably not well documented percentage of patients that want surgery, and as whether it's military insurance or commercial insurance.
Maybe just top surgery or just facial feminization.
Oh, right, sure. There's a variety of surgery.
But of our population that are transgender want something.
Correct. And
so
and whether or not the military population is translatable to the entire transgender population, there's probably some question there. But
I think you brought it off when you say if it's available and if it's paid for.
I agree, absolutely.
I'll go get something.
It's not just paid for.
Tomorrow,
No, the financial barrier through the insurance coverage is no doubt probably the biggest rate limiting step.
It's that plus availability. The leading trans surgeons for trans women have a 3-year backlog.
Yeah, for the genital reconstruction, it's limited. There are.
They're getting to meet new people. I maintain lists, and like 24 people appeared in the last year. Some of whom have never performed surgery.
And that's what I was. Yeah, and that's the point I was making earlier. Like, patients really have to do their research. When I was just preparing for this talk and doing research online, there are a lot of websites that list surgeons that do genital reconstruction, but there's no data showing how many they've done, what their complication rate is, what their.
And one last thing.
Yes.
There is Thailand, which probably does more American gas surgeries, gender affirming surgeries than the U.S. does.
But there is a complication, right? There are 3 Army individuals that went to Thailand on their own time with their own money, and 2 of them are permanently disabled. 1 cannot fly.
I had the pleasure of escorting a patient who did that to the emergency room here at Vanderbilt when I was active.
The surgical arena, particularly with the genital reconstruction, is much more in its infancy than, hysterectomy is pretty straightforward, and you should be able to find a doctor that can do a hysterectomy. Breast augmentation is pretty straightforward, but some of the genital reconstruction, which is what a lot of these patients are considering, is much more murky.
And like you had said, I think, their names are not available, so you don't have a camper, but they're doing it to reconstruct your urethra. Now, urologists think it's pretty tough.
And that's why you see a complication rate of 30 to 40%, which there's not a lot of those surgeries out there that have that kind of astronomically high complication rate. So you had a question?
Yeah, so a person who's from
Speak up just a little bit so everybody can hear you.
So a person that's going from male to female transition, if they're taking the estrogen, but if they don't take all of the medication, will they still have dysfunctions on the lower, the bottom part, if they decide not to do away with the surgery?
Are you talking about as far as future fertility and being able to heart? So That's a great question. I'll be honest, I would probably have to defer to like an endocrinologist to answer that question thoroughly. I don't know to what degree, how much, if you are subtherapeutic on your estrogen by serological measurements, how subtherapeutic you are as far as how much sperm you may or may not produce. I don't know that if I have a great question, or I certainly haven't come across any literature that address that. It makes sense that perhaps if you were subtherapeutic or lower dose, I don't know, Dr. Bullock, if you have seen any literature about that. I have not seen literature looking at various levels of serum estrogen versus retained ability to produce sperm. So,
I think hormones are so variable in what they do. You see some bodies, probably, even with a study, you probably never tell an individual person that theirs is going to be at any level. You still have to give your usual counseling that estrogen is going to permanently affect sperm, and we're not sure how long it takes. But.
Yeah, I mean, I think we can speak in broad generalities to patients, but I think, for a patient who's been on estrogen or is considering estrogen and considering future, if a patient knows they want to transition and knows they are going to be on estrogen, it may be worth telling them, collect the semen sample before starting your therapy. That's obviously the easiest way to do it. But for somebody who comes into your office who's been on estrogen, you have to say, look, this has probably affected your fertility, but let's get a sample and we'll see to what degree, and maybe, not much at all, maybe significantly. Dr. Bullock gave an example of a patient they were having impulse clinical with her to try and retrieve some sperm. So I think there's a wide variety there, but I'm not aware of any literature that specifically says something like that.
It seems like in my little bit of experience where I've had patients that have gone back and tried to do semen collection so that they could, for fertility reasons, I don't think it takes very long or very much estrogen to shut down sperm production. I think it can come back if it's not been a very long time, but I don't think it takes very much to shut it down.
I don't have a definitive answer, but I saw one study once that said inside of 6 months, essentially sperm production stops.
Yeah.
For the gender confirming bottom surgeries, which surgical specialties cover those cases, and does the rate of complication matter by which specialty is doing it?
Great question. So it depends a little bit on the surgery you're talking about. Creation of neovagina has traditionally fallen under either urology, plastics, but also gynecology. We certainly have patients that, whether it's through a birth defect or other cases, or through radiation therapy, otherwise might have to have a neovagina created, and we've done that sometimes in GYN oncology, and sometimes even in benign gynecology or urogynecology. Urology, of course, for trans female patients that are sort of genetically male, I guess, they are familiar with that anatomy, that native anatomy, whereas I am less familiar with native male anatomy, obviously, as a gynecologist. So they do some work in that area, and they certainly would do like a penectomy or the orchiectomy. But probably the biggest group that does general reconstruction are probably plastic surgeons, certainly by what I've seen in my research for this presentation, it's probably plastic surgeons. Our new chair of plastic surgery here is very interested in having some of his professors trained to provide general reconstruction, but I think it's a collaborative effort. As far as complication rate goes, that's really more related to the surgical experience of the surgeon rather than a particular specialty or not. If somebody's done 100 or 1,000 of them, they're going to be much better than somebody who's done 10 or 15. So that's much more related to surgical experience, which is why it's a little bit of a chicken and the egg problem when you're trying to start a program. You don't want to get somebody trained and then they don't have any patients to operate on for a while, versus you don't want to have a huge need and not have anybody to provide it. So when people are getting trained or thinking about getting trained, you need to really go to a high volume center for a long period of time so you can do a lot of procedures, see some of the complications, manage some of the complications, so that you come back to work, you're sort of well versed in what it is, and you don't need to have maybe quite as regular procedures to maintain your skill set.
You sort of touched on the question I was about to ask. As a first-year medical student,
Sure.
If I were to go into this for my practice, what path would I take?
Going into what specifically?
Gender affirmation surgery.
Sure. So again, you can really take one of 2 or 3 routes. Probably the most direct route would be probably plastic surgery. So that would be through surgery and then either plastic surgery fellowship or plastic surgery residency in and of itself. By the time you've got 8 years or so ahead of you. So by that time, there may very well be other fellowships available, but so that you can get that training. As we're seeing more and more patients get surgery and more surgeries be covered, so there may be other options for you over time, but certainly probably a surgical or urologic. I would hazard a guess that most of those surgeries will fall ultimately under either urology or plastic surgery rather than gynecology. But I think a lot of them will be done as joint surgery. So like as I do the hysterectomy, somebody may come and do, vaginal reconstruction coming as a combined surgery. So either way.
I don't think I could ask you about the sort of like adverse experiences. I am also a medical student.
Sure.
And I have some classmates who sort of feel like this kind of cultural competence isn't an important part of their wheelhouse of striving for excellence as a physician. And I wonder how you encounter that at work, and when that happens, how do you make the argument to people that this is important? Because I have had that conversation many times and variable levels of success.
Yeah, it's a great question. Unfortunately, it's a very complex question. So, I think it begins with, like I said, we get training in sickle cell anemia, we get training in cystic fibrosis and other things. But as a society in America, we are not comfortable with sexuality and with gender and gender identity. You guys are more comfortable with it than my generation, and my generation is more comfortable with it than my attending generations, right? So it's changing, but it's by no means there yet, because I'm teaching you, and I was taught by people older than me, so it's going to take a while to get that through. You guys do a great job of being advocates for the LGBT community, and so I think you see changes being made. I know that this medical school is very different than when I went to medical school 15 years ago, but I think the other part of it that you look at, and I think where part of it comes up is, for better or for worse, it's still a very small percent of the overall population, and so I think when you look at where our education resources focus, where our clinic education resources focus, if you only have a finite period of time, you try and get the big items done. I'm not saying the big items are more important than some of the other items, but I think that's probably where some of that bias gets sort of institutionalized. And then lastly, I think, there are a lot of people that are simply not comfortable or not supportive, whether it be for religious reasons or cultural reasons or whatever, of LGBT population in general. I mean, I had a very long conversation with one of my current colleagues who was really pushing me about why I deliver transgender health care in the first place and why I felt that was necessary. And he was incredibly respectful about it. And it was a really interesting conversation to have, and I really appreciate having that conversation with him. So I think it's important, as much as it's important to understand, the LGBT lifestyle in those patients, it's also important to understand people that are, maybe not as comfortable with it. Because if we don't really understand each other, you're never really going to get anywhere. So I think it's important to have those conversations with people that you may perceive being anti this or anti that. Because a lot of times they're not necessarily anti this. They're simply uncomfortable with it, or they have maybe very personal to them, very legitimate reasons why they don't agree with it. My point being is that those people are still in the institution as well, and they're in the world as well. And so, I think all those factors, whether it be just a generational cultural change and how comfortable we are talking about gender and sexual health, the amount of time available to educate staff and providers and medical students and all the stuff that we have to get you guys through in 4 years. Does it make sense to spend more time talking about hypertension, or make more sense to talk about transgender health? So I got to pick one. I don't know there's a right answer there, right? So, and then again, there's cultural and religious beliefs that sometimes can impede that progress. And so I think it's a multifactorial reason why that is not a bigger priority. I'm not saying that's a good excuse, but that's probably the reality of the world that we live in. But I think it's incumbent upon you guys, and I challenge you to try and help change, certainly the medical school administration about it, and challenge your attendees and come see me when you're under the joint invitation next year, and we'll talk about it. And that's something, because if you guys don't bring it up and really help force that change, the change is not really going to be.
Yeah, I comment on that. I think it's really
Yeah.
I mean, one of the things that we're all pledging is that we want to do no harm, in healthcare. And I think if you're alienating any part of your patient base, whether you agree with their choices or not, whether that's drug use or sex or gender identity or whatever, then you're doing a disservice to them. So if you're going to take your oath seriously, and you want to at least be educated as to the transgender population and their needs, and be able to refer them to somebody who can provide compassionate, competent care if they're not.
Yeah.
That's the argument I would make, and then not try to convince somebody anything other than that.
Yeah, I don't think we're trying to convince people to change their mind. But
I didn't want to
think
say
that two-way education.
They're right, but you're not going to change their mind. But you can at least put it in context that they have bought into. They've bought into doing no harm.
Yeah, and still provide the patient with the care.
As a nurse, where can I go and get more education for nurses or LGBT health classes? Or
That's somebody right behind you. You can probably give you that answer.
I did a class for nurses at Vanderbilt a couple months ago, and I'm doing another one at Burlington Hospital in April.
Patty Detzel's one of the nurse midwives in the Department of OBGYN and is very knowledgeable about transgender health. So she provides those classes.
and then another question I had, when you open the clinic for Gender Health later on this year, are you going to help provide education for those seeking gender confirmation surgery, what questions that they need to ask so they can reduce adverse outcomes?
Yeah, so I think, part of the goal is the providers that will be at the clinic, regardless of their specialty, will be knowledgeable and capable of providing really comprehensive and competent and integrative care. And so I think part of our job as providers for patients specifically that are seeking surgery is if the patients aren't asking the right questions, that we need to pose those questions to them to say, hey, have you considered what this means for your future fertility? Hey, have you considered the high complication rate with urethroplasty? Hey, have you considered what it might mean for your future hormone needs to have your ovaries removed or not, so that the patients are making a really informed decision. So I think the surgeons that, and even the non-surgical services that will be there will be educated to help make sure the patients are fully informed and making appropriate decisions that they are comfortable with and understand what those decisions mean. So yeah. Any other questions or concerns, Aaron?
Yeah, you talked a lot about ongoing cancer surveillance. What about bone density screening?
So, great question. So for the trans female population, those patients are typically on estrogen, and their bone density screening would be the same as.
They on it forever, or do they come off of it?
So most of those patients will stay on it, although there's a lot of variability. And certainly, if they did come off of it, you would treat them. If they've had their orchiectomy, which many of them will have had, you would essentially treat them as sort of postmenopausal or ahormonal. And so you'd want to screen them earlier, potentially put them on bisphosphonate or something like that to help with their bone density. For the trans male population, again, as long as they stay on their testosterone, they may stay on it forever, because men make testosterone much longer than women make estrogen. They should be protected for the same reason I won't need a bone density scan until I'm considerably older, kind of thing. So from that point of view, that's sort of how you would do bone density screening.
There's no guidelines from the organizations at all. They just use your best guess for if you're still on hormones or not on hormones.
Yeah, and these are all sort of generalizations based on cisgender populations that we know of right now. Any other questions or anything else again? Yeah.
I'm trying to figure out how to ask my question.
Sure. This is all super straightforward.
Yeah. So one of the things that you said a little bit ago in response to one of the medical student questions was kind of this idea that that the change is very generational, and that the young generation is going to really be kind of responsible for kind of pushing.
I think so, probably, yeah.
Yeah. And so I'm wondering, structurally, how we do that when there's also this severe need, because I think the students you were asking, it sounded like they're not going to be in charge and have the power that's needed to create the change for many years. So how do we, knowing that this age piece is in place, how do we encourage accountability in the older generation?
Yeah, it's a great question. And I think, I think Jesse really touched on this when he gave his opening remarks. And I'm blanking on the other professor from medicine that spoke. I'm blanking on his name, and I'm sorry. I'm sorry? Yes, thank you, Dr. Churchwell. You know, when Jesse got here, a year after he got here, he realized there was no LGBT health program. So he went to the administration and said, you know, WTF, we need to have, you know what I mean? Like, and he went to them with the data and said, you know, this is what we need. This is how we can do it. We need to do this. And they understood that, you know what, we've been overlooking this, and this is something we need to do. And I think, you know, for y'all's generation, whether it's transgender health or other health, you know, disparities that you see, you know, I think you'd come in.
At Vanderbilt also, if you're aware, there's the students, the Stonewall, they come and talk to the med students. I think it's optional right now, but somebody could make it like a requirement.
Yeah,
I guess
but
what
I
I'm
guess,
asking isn't about the students. I'm asking about the people in power now. Like,
right, so I think, you know, hold on one second. I think, you know, what you have to do is if you see, you know, policies that you want altered from the people in power, is you approach the people in power and say, this is what we think we need to have done, and this is why, and you know, really educate them about why that changed. And I think, you know, Vanderbilt for Better, I think, is a place that's very open to the idea of being malleable and changing policies and changing care guidelines. So I think if you see a disparity, whether it be in any patient population or a need that's there, you know, bring that to our attention, and we'll address it and incorporate it into curriculum and make those changes. Yes, ma'am.
I want to give credit. It wasn't just Jesse. I've been here a long time.
Sure, yeah, of course.
One was a medical student, which he mentioned this morning, Kristen Eckstein, a friend of mine. And the other was a PhD student, Caleb Edmiston, who was a trans man. He was very active in getting this started. So it's not just that Jesse woke up one day and said, oh, this is something we need to do. It's that students came to him and said that we have this need, these things we want. They founded the Trans Buddy program. They started the whole thing.
Vanderbilt has a long reputation of being a sort of bottom-up driven place. And so certainly if you see any sort of concern that you think needs to be out there for any patient population, I encourage you to bring it to your professors and your attendings and say, hey, what are we doing for this? What are we doing for that? How can we do this better? These are how other institutions are doing it. So.
The hospitals are super, I mean, even the most conservative people are responsive to money,
Correct.
competition for benchmarks. You know, that's easier for the hospital population than the regular campus population, but in comparison to benchmarks, in comparison to some of these national databases, that's the kind of information you bring to them if they're not super, you know, progressive socially.
So out of respect to the other speakers, I think it's 3 o'clock, and I think there's some other speakers who are about to speak downstairs, so we're going to go downstairs. But certainly y'all can reach out to me anytime you need if you have any other questions about the presentation. Hey, how are you? Adam, yeah, nice to see you. Oh, fantastic. I do have a car. I sure do. Sure. Come on down. Yeah. Yeah, you can get to Shane Taylor, the director for the Clinic of DPs. So you can get yeah. It'd be great, yeah. You guys want my cars. Oh, excellent. Wonderful. You're in Australia. Fantastic. How long are you here for? Where do you live in? Gotcha. Hey, yeah, it's great to meet you. Yeah, you did a great job. Thank you. No, I've not been in touch with Australians. Most of the big transgender centers that I know of are in Europe, particularly in Germany or some really big ones. That's not to say that there aren't any in Australia. I'm just not aware of them. There may very well be. The whole sector don't come up in the public. But I don't know that regional limited. Yeah, they have a bus system or
Yeah, I just like I'm happy with your research, and that's why I'm asking.
Of course, yeah. So those are certainly right now the two biggest. And like I said, as an OBGYN, it pains me to say this, but those are probably the specialists that are going to help that. Again, because for trans female patients, that's male anatomy. I don't do male anatomy, so I think, but I don't do the same urology stuff, right? So they know that too. Plastic support is all I've used to something like anything else, like the community, so they can do anything anywhere. And I use that skin grafts and all the other things, right? So again, not that I can't learn. So I suspect that plastic urology will dominate. But I could be wrong. So definitely. Yeah, that's right. Absolutely. Yeah. Nice to meet you. Absolutely. Yeah, take care. Hi. Hey there. How are you?
Hello.
Nice to see you. How are you?
Very well.
Well, thanks. Sure. Yeah. Is that?
I wonder if there's any sort of opportunities for gender
As a gender.
I would think so. I would talk to probably August, September. Say I would love to get involved and get
Oh, really?
Hey, I want this in my radar for 2018-19.
Yeah, absolutely. Well, actually, I'm finishing it.
So then, if you're graduating, probably shadow, probably, but if you're going to work at Vanderbilt, if you work in medicine ACC,
What's the class?
what's your specialty? Sure, I would reach out to you. I'd like to work at Vanderbilt. I'd really like to work at part-time. It's a 25 days, right? 5 days a week.
Right.
So you could work and this is one and then 5 months open. Do you want to go last? Reach out to me. Reach out to me or to Taylor. I brought a whole bunch of it. Yeah, what's going on? Well, how are you?
Yeah, Sandy. And so are all of us. And some of us are interested.
Yeah, that's all right.
Like certain specialties.
Yeah, of course.
There's a lot to like.
Would you want in?
Maybe. Yeah, I would love. I mean, I